All right, welcome everyone to a new episode of the Roscoe's Wetsuit Podcast. I am your host, Toby Passman. On the show with me today, I have a very special guest, Dr. Sandeep Nayak. Dr. Nayak completed his MD at Brown University and his psychiatry residency at Johns Hopkins Hospital. He's primarily focused on investigating psychedelics as treatments for psychiatric conditions, particularly addictions and mood disorders. He's also interested in psychedelics' effects on belief formation and expanding diversity in psychedelic research. Dr. Nayak also works as a psychiatrist at Addiction Treatment Services at Johns Hopkins Bayview Medical Center and is clinically experienced in treating disorders of mood, anxiety, eating, as well as addictions and OCD. Dr. Nayak, welcome to the show.
Thank you. Glad to be here talking about all this stuff.
Yeah. So tell me, this is such an interesting area of research. I want to hear how did you originally even find out about psychedelic research, and what sort of drove you down this path?
Well, so for me, psychedelic research is just a very appealing combination of many things that I've been interested in most of my life, which I didn't actually think could come together. Most of my life, they just felt like pretty separate, disparate interests. I first became aware of psychedelics when I read Aldous Huxley's Doors of Perception in middle school. And that kind of made an impact on me because I was very interested in religion. I was raised Hindu and was also exposed to a lot of Buddhist ideas and was surrounded by evangelical Christians. So it kind of forced me to think about the differences between these. Basically, I was kind of intrigued by mystical religions when I learned about psychedelics in the context of Aldous Huxley, which he really introduced a lot of the mystical concepts and language that subsequently began to be applied to psychedelics. Separately, though, I knew that I wanted to be a doctor, a clinician. I was interested in the brain, and I studied Buddhist philosophy in college. And they just kind of felt like separate things. I went to med school, ended up deciding I wanted to do psychiatry because I was particularly drawn to mood disorders and addiction treatments. And as time marched on, here are this burgeoning field of psychedelics in which all of these different elements are actually relevant. You've got novel treatment for various psychiatric conditions that need new treatments. You've got this kind of interesting mystical aspect to these experiences that seems to somehow be beneficial. And yeah, it just kind of naturally fit with pretty much everything I'm interested in, which is why I gravitated towards it.
And what have been some of the most interesting kind of findings so far with the research that you've done with psychedelics, or that has come out of your lab?
I mean, there's been a number of things. There's clinical research and there's non-clinical research. And I'm a clinician, so I gravitate more towards the clinical stuff. I think psychedelic therapy has the potential to be of interest to people who don't have any real interest in psychedelics, just by virtue of, it potentially being clinically useful. So, there is a study that was open label in which people who'd been smoking tobacco tried to quit a number of times, were unsuccessful, were given psilocybin, and they had pretty remarkable quit rate that was quite durable. I think it was 60% at 6 months. I would have to actually look that up, but it was way higher than any the next best treatment. It just simply worked much better. So all of these need to be followed up with kind of more rigorous studies, which is actually being done. But I'm excited by the prospect that relatively short interventions, psychedelic therapy, you meet with somebody several times over the course of weeks, have one or a number of dosing sessions, then you have integration sessions. But studies with, smoking, depression, not just at our center, but at others, seem to show that these can produce durable clinical effects that
Right.
are
So,
powerful.
so you mentioned psilocybin, and for those listening, so that's magic mushrooms. Uh, so psilocybin, tell me a little about how do we know kind of the mechanisms for how that's working with smoking cessation, and can you also just kind of talk a little about how what we know about how it's working, how it influences brain activity?
Yeah. So mechanisms. So this is actually a problem within psychiatry generally, um, but we can know exactly what receptor a drug acts on, which we do know for the most part with psilocybin. And then we can know kind of next level up various ways in which a drug, say psilocybin, can perturb brain activity. And then we can take the next level up, which is that what do people subjectively feel? And we can know all of those things and still have trouble connecting them. So kind of at the lowest level, what all classic psychedelics, whether it's psilocybin or LSD or mescaline, act on the serotonin 2A receptor. They're agonists of that receptor. And that receptor is kind of spread all throughout your cortex. And that seems to explain why these drugs act similarly. They all act on that receptor. And I'm not really a neuroscientist or a neuroimager, so I can kind of parrot to you things that others have found. But one of the findings from neuroimaging studies is that psychedelics seem to reduce activity in what's called the default mode network, and this is a network of brain regions that is I think it was initially discovered in fMRI studies when they were just trying to scan people's brain when they were not doing a task. And it turns out that when you're not doing a task, your brain is actually still active. Um, and it's thinking about, past memories, what do I need to make for dinner, a lot of self-related narrative stuff. Anyway, so one of the findings seems to be that psilocybin breaks the default mode network. And this is kind of parallel to research in meditation as well, which seems to show similar neuroimaging findings. So subjectively, though, people seem to feel that, if you'll let me ramble a bit and I'll try to circle back and connect all these. People, psychedelics are being studied for a variety of conditions that are like, how could one treatment be useful for depression and for addiction and of various kinds, and yada, yada, yada. Existential anxiety with cancer. How can one treatment be useful for all of these different things? And yet we do have other treatments that are useful for a lot of things, namely psychotherapy. Psychotherapy is very effective in a transdiagnostic way. It's useful for all kinds of stuff. And so I kind of, and probably a lot of psychedelic researchers sort of think of psychedelics as acting therapeutically in a manner similar to psychotherapy. In other words, people are having these insight experiences, cathartic experiences, corrective emotional experiences. They're able to see their life in a new way. They're able to see the problems in a new way. They're able to think and act differently. And so it may be that some of those kind of acute effects that you're seeing in neuroimaging studies, for example, breaking the default mode network, you're kind of scrambling up the normal ways that your brain is processing information. A metaphor is used about getting your brain out of ruts, which most psychopathology relates to a kind of mental rut. Depressed people are stuck on negative beliefs, attitudes, worldviews. People with addictions are stuck in certain behavioral patterns, including how they respond to stress. OCD, anxiety disorders, these all kind of relate to sort of stuck attitudes, stuck behaviors, stuck whatever. And so that's one way in which you could maybe link up some of the acute effects that are happening to some of the more subjective effects. It's not 100% clear that's the case, but that's one way that it's described.
Okay. And you mentioned something earlier about kind of like the sessions that sort of accompany the sort of psilocybin treatments, right? So there's therapy sessions, is that correct, that are sort of going along with the actual administration of the drug?
Yeah, so they're not necessarily called therapy. They're and this is where like my own thoughts about this might start to diverge from others, but you basically have these preparatory sessions with two kind of kind, warm, compassionate people who get to know you quite well over the course of, many hours, not all at once, but get to know what kind of problems you're going through, get to know who you are, get to understand a little bit better what kind of changes you're hoping to implement in your life and experience. And you basically end up building like a clinical rapport. So clinical professionals can sometimes build relationships with people really quickly that are very intimate and powerful because you don't owe your psychiatrist, you don't owe your therapist anything. You don't They're there for you, if that makes sense. And so you can be open with them in a way that you maybe can't be with other people in your life. So anyway, that is like that relationship is a very, very powerful thing in psychotherapy and any clinical experience, including I think psychedelics. So that's what you're kind of going into as a study participant when you actually get dosed. You have this powerful relationship with these two people that you feel like ideally know you well, that you trust. And so that's the context in which people then have the experience, which can bring up all kinds of stuff. It can bring up ecstatic experiences, it can bring up traumatic memories, it can bring up just a general life review, sort of taking stock and thinking about things differently. And with the encouragement of people that you've come to trust to just sort of accept the experience and go along with what's happening, which a lot of times we don't do in life. We push things away. We kind of try to move around obstacles. We hide from the things that make us uncomfortable. So you have the relationship, you have this profound experience. You're also at the same time kind of practicing new skills, how to accept what's happening. And then after that, then you talk to these people and sort of process the experience, kind of leave meaning of it. So that all I think is quite psychotherapeutic.
Right. So the people, I'm curious, the people that are leading these sessions, what are their instructions as far as how do they sort of help people, kind of cope with whatever's coming up? Are they sort of traditional like psychotherapists, or like who even are the people that are leading these?
Not, yeah, they're not, they have kind of different trainings. So you'd be a little, maybe be a little surprised. It's not like, even though I'm calling it psychotherapeutic, it's not, they're not really doing psychotherapy during the session. They're not necessarily trying to guide people towards certain insights or, steering them. They're just there. Um, and they may just be a comforting presence. They may not talk for a long time. They may, um, but they're kind of there to help people engage with the experience, and with the idea that, which seems to be the case, that the preparation and the individual's intention and all of that ends up leading them to have experiences that can be therapeutic. So, this is a range of people. It could be a psychiatrist, it could be a social worker, it could be various types of people.
How much does I guess like personal like I guess what I'm asking is like, do they need to be, does someone need to have like firsthand experience like taking these psychedelics to sort of be able to be in a position to help someone else kind of to be able to guide them through it? Like it seems like it might be difficult if they didn't have firsthand experience. Is that accurate? Does that kind of jive with what you've experienced or no?
It's kind of a thorny question you're raising, but not necessarily. I think there are there. I mean, there's a tension with this is clinical research, right? So you have the clinical aspect and then you have the research aspect. So the there is a concern with, let's say that you require people to have a psychedelic experience in order to be a guide, that there is a risk that you run of uh, damaging objectivity, I guess you could say, um, or introducing bias potentially. On the flip side, it is potentially helpful to be able to understand the types of experiences that people are having. So it's not anything that's written in stone. It's not like a requirement by any means. It's not. I don't think that somebody is necessarily doomed to be a bad guide if they don't have psychedelic experiences. Sort of relates more to the way that one relates interpersonally. And you have to be sort of a sensitive, understanding, kind of empathetic person. Um, and certainly having some experience of altered states, whether it be meditation or holotropic breath work or any number of other things, I think would be beneficial. Um, but not necessarily having, I don't think necessarily having a psychedelic experience would be required.
Okay. What can you tell me? I saw some really interesting stuff coming out about psilocybin and end of life anxiety. Is that something that you're familiar with that research?
Yeah, that was a study out of here and NYU, um, that that contributed to some of those findings.
And so can you kind of walk me through as far as like how do we know that or I guess like what mechanisms is that acting on, and how is that sort of helping people come to grips with like, you know, realizing that they're dying? I mean, that's something that seems to not be usually explored. I mean, with any sort of drug or therapy, it's a really interesting study.
Well, it's certainly not usually explored with drugs. I would kind of push back a bit that it's not explored with therapy. Um, like Irvin Yalom, who's a existential psychotherapist, is really kind of all about that, death, like the relationship with death. I think it's something that in at least American culture is pushed aside very often. But anyway, so the study, I'll just speak about the Hopkins one. It was recruiting people with depression, anxiety symptoms with um, diseases like cancer, very serious diseases, and didn't necessarily mean that they had an anxiety disorder or major depressive disorder. They had symptoms, and I guess some of the idea behind this is that people are having symptoms because of the experience they're going through of having a life-threatening illness. And there's a lot of anxiety around that, understandably, including, life unlived and the prospect of death, not being able to accept that, not being able to make peace with the time that's left, any number of things. And so I think you asked about the mechanism, right? I think this is another example where it's difficult to boil it down to something at a lower level than the subjective experience. So things that people report after psychedelic experience, things that can happen during a psychedelic experience are having just a greater sense of connection with various things, people, the world, having greater sense of acceptance of death, feeling part of some of these mystical experiences can lead people to feel like they're part of something greater than themselves. And that can be in very mundane ways, like they're more connected to their spouse or their friends or their community, or even something grander of nature. And this can potentially help explain some of the greater acceptance of death that people may feel after these experiences. There's another part to your question, I think.
That was basically the gist of it. Yeah. I guess I wanted to switch gears a little bit and ask you about what's your take on microdosing? Because I know that's something that's been kind of reported in a lot of media outlets nowadays. But I guess one of the main criticisms that I've read about it is there's not really much research that supports these kind of anecdotal claims.
Yeah. The short answer is I don't really know. I believe there was a study that just came out of Maastricht with LSD microdosing. I haven't read the study, so I shouldn't really be talking about this, but I think they used LSD microdosing for pain and showed a positive result. But I think there's a lot of enthusiasm about microdosing among people who microdose. It's certainly reasonable to think that there's something worth looking into there, but I don't think we know enough.
Okay. How about just as far as like the doses that are used in just whatever sort of studies that you guys are doing? How are those sort of decided upon? Do you guys try different dose ranges, or just how is that kind of figured out?
So all of this happened before I kind of joined the field, but the doses that are used are large, like they're pretty high doses. And so one of the more common doses that's used is 30 milligrams per 70 kilograms, which I think equates to about 4 to 5 grams of dried psilocybin cubensis mushrooms, which is like fairly large. There were studies earlier that used lower dose, like a range of doses, to try to kind of pin down perhaps an ideal dose. So it is a bit of a balance. The kind of the goal of psychedelic therapy is to produce a very powerful, meaningful experience. And so the higher dose ranges were sort of arrived upon because they're more likely to produce those experiences. But they're certainly not like small doses.
Right. Well, something that really interests me, just the whole framework of giving like very large doses, I guess, infrequently. Because I mean, most, psychiatric drugs that are currently available, to my knowledge in this country, in the kind of Western medical system, it's sort of like a daily, right? Your doctor prescribes, you to take a pill every morning or something. So it's interesting that that these long-term therapeutic effects are able to be seen even with giving a drug so infrequently. Is that,
Yeah,
do you find that sort of unique in the way psychedelics work like that?
kind of. Like yes and no. Because I think there are actual parallels to other treatments. For example, it's obviously very different from, say, taking an SSRI every day for months to years. But there are other treatments that are sort of intense and time limited and can have enduring effects, like ECT, shock therapy. With some exceptions, people aren't getting ECT regularly. Um, but I think I think part of the enduring effect of psychedelic therapy is therapy. I mean, people change the way they live their lives. They change the way that they view things. And psychotherapy can also have um, enduring changes, enduring benefits after people stop doing therapy. So in that way, I don't think it's just the drug. I mean, I don't think you ever really get just the drug with the psychedelic. You get the drug plus the setting, and everything else surrounding that. But there is, there is an afterglow effect where, in the immediate aftermath of a psychedelic experience, people feel like much more positive mood, and they may. I guess what I'm trying to say is that you can still lose the effect. It's still possible to lose a benefit from a psychedelic experience. So I think the studies that are going on currently have like really good attention to the preparation and integration, but I suspect if that was stripped away, you might not see as many enduring benefits.
Okay. So if you are, say, a psychiatrist, eventually, well, actually, first off, I guess I want to ask you where, as far as like the legal framework of things, when do you think psychiatrists are going to start having access to these different psychedelic therapies to use?
Um, I'm not sure I'm the best one to ask about this. I think
Okay.
maybe before COVID happened, assuming, I mean, there's phase 2 trials going on for, at least for depression, psilocybin. The next step is phase 3, which then, after that successful phase 3 trials, when you can get FDA approval, which is when drugs can actually be used. Um, I don't exactly know what that, if you remove COVID from the picture, I think maybe it would have been, if everything went really well, I think it would have been maybe like 5-6 years.
Okay. So
Maybe.
so when that does happen, so as a psychiatrist, because you work as a psychiatrist at Johns Hopkins, so how do you sort of see, how would you implement these different kind of psychedelic modalities into your work ideally?
Um, well, it's a good question. So I, again, this is something that I think, like my own views on this might differ from others. Just take that caveat, but I actually see psychedelic therapy potentially being very complementary to conventional psychiatry, rather than like an alternative or a totally different framework. I don't see it as being, it's obviously very different, but I don't see it as being fundamentally just a different entity. And so I kind of think of it like any other therapy, in the sense that you're always going to have a patient, an individual patient who has individual problems and individual preferences. And so you might, for example, get a patient who's very depressed, but is very against conventional psychiatric treatments, who may, because of reasons of preference, be more open to psychedelic therapy. That could be a route in which somebody, alternatively, you might get somebody who has no interest or proclivities towards psychedelics at all, who is very depressed and has tried a range of psychiatric treatments, none of which has really given any enduring benefit, who may, for that reason, be interested, and kind of everything in between. So I don't really see, even if psychedelic therapy lives up to its promise, I don't really see it supplanting traditional psychiatry. I see it as being an additional tool that can be used. And it's a broader tool. I mean, I don't think psychedelic drugs are strictly a psychiatric tool. It's used for all kinds of other things. But I see it as being like another thing in the armamentarium, if that makes sense.
Right, right. I wanted to ask you about, I guess, in using these sort of psychedelic therapies. Just before we started recording, we were talking a little about kind of belief formation, and I'm curious with like the use of these things. It seems like it could really, sort of shatter people's worldviews or just how they see themselves and other people. Is that something that, like, do you think that's always a positive thing, or do you think that someone that could potentially like affect someone in a negative way as well?
Yeah, it's a great question, um, and I think the answer is unclear. Like I think it could be both, and so I think part of the question you're asking is like, how can you tell if a belief change is harmful? And it's if you have a treatment that causes 1% of people to lose their arm, it's pretty easy to say that that's harmful, or that causes people to have whatever. But what are the difficulties of deciding whether or not a given belief change that may be occasioned by a psychedelic experience is harmful or not? Is harmful from the perspective of who? So the nature of belief change is that there is someone on one side of the experience who believes one thing, someone on the other side of the experience who believes another thing, and those two people may have actually different preferences. And so I think it's a little unclear. There are, one, I think we need to just know more about the degree to which beliefs can change and what types of beliefs are likely to change, which requires more research. But two, that should just be something that's included, I think, as part of informed consent once we do actually know more about that. You have like, I mean, this is a particular concern with psychedelics because people become open to all kinds of ideas that they maybe wouldn't have otherwise. So Stanislav Grof is this Czech psychedelic psychotherapist who has developed like a really kind of intricate system of psychedelic therapy that involves like the literal idea that people's psychopathology, their suffering, relates to their birth experience, birth trauma. And So I mean that's a bit of a fringe idea, a very fringe idea, we might say. Yet people that he has uh, guided will have these experiences of recalling their birth or even recalling their conception. And the meaning that is made out of those experiences is therapeutic. So you're sort of, at least I'm kind of caught wondering, so is that good or bad? Um, Now, people aren't really having these birth recall experiences in like the trials and the research settings, I don't think. But Stanislav Grof is like, subtly or not promoting those ideas that can then lead to people having them potentially. So
Uh,
I think at the very least, it is cause for caution to be like not imposing for a psychedelic therapist to not impose one's own ideas onto others.
right, right. And while you were sort of answering that, it also kind of got me thinking as far as like the different, I guess, like sort of types of personalities and how that might affect, whether if someone's super kind of open to new experiences, right, versus, being very like closed off and very like rigid in their belief system. It seems like that could really play a big part in sort of people's experiences with these things.
Yeah, that's a great point. Um, Certainly, I think like personality probably does have an impact on psychedelic experiences. It makes sense that it could have an impact on susceptibility to change, but also all bets are off. I mean, psychedelics, like personality is generally thought to not really change in an enduring way after adulthood. I mean, that's the dogma. Yet psychedelic like openness, which is a facet of personality, it can increase after psychedelic experiences in an enduring way. So it personality going into an experience could have an impact on the experience. I think people with more neuroticism are more likely to have challenging experiences, for example, but the personality coming out could also be slightly different. And so you could imagine that somebody who's very, very open-minded might be more open to belief changes, but somebody who's not open-minded, there's more room for belief change potentially.
That's a good
So
point.
it's sort of hard to say to conjecture what the effect would be.
Yeah, yeah, it's interesting to think about. What are there any conditions that you definitely would avoid psychedelics in a psychiatric setting? Like I've sort of read about the sort of psychosis sort of being contraindicated, schizophrenia. Um,
Yeah, yeah. I mean, I like the short answer. Yes, there are conditions that I would. Um, so things that are a little unclear. I have personally seen psychedelics cause mania with bipolar mania 3 times. And the thing that I kind of believe but can't prove is that I suspect psychedelics are more problematic for people with bipolar disorder. I mean, the general exclusion criteria is psychosis generally, and I think that absolutely makes sense. But I suspect that psychedelics are particularly problematic for people with bipolar disorder. That doesn't mean necessarily that that should not be done ever. Um, a lot of treatments for depression can cause mania in people with bipolar disorder. So, for example, antidepressants can cause mania. Bright light therapy which is antidepressant, can cause mania. Sleep deprivation therapy, which is actually in short term can be like remarkably antidepressant, can cause mania. ECT can cause mania. So psychedelic drugs can cause mania. So I think there are ways for those other conventional depression treatments that obviously if you have somebody with bipolar disorder who's depressed, you want to help them and you don't want to hurt them, but there's a way in which you can try to balance the risk. And so antidepressants, again, which can cause mania, are actually used in bipolar depression, but the idea is that it's usually given along with a mood stabilizer or something that could mitigate the risk. So we know that there is a risk for bipolar disorder with psychedelics. We don't know how big the risk is, and we don't know how much the risk can be mitigated. And so it's like a little, we just need to know more, I think, before proceeding. I don't think there's necessarily any hard and fast rules, but without actually having a clear sense of risk and the degree to which risk can be mitigated, it absolutely makes sense for there not for that. Those are people that should maybe avoid psychedelics.
Right. Have there been any studies like looking at like either the synergy or like adverse reactions of, say, combining psychedelics with, if someone's already on SSRIs or taking other psychiatric drugs? Is there any research looking at how that, if there's any contraindications or
There are, so we're actually about to launch a survey on this, but there is one survey from the 90s by Kit Bunsen that looked at the interaction between, it's a retrospective survey looking at interaction between psychedelic drugs experiences in people who are taking other drugs. And some of the takeaways from that, again, it's like you take it with a grain of salt, right? But because for some of these drugs there wasn't a lot of respondents, but some of the takeaways, that one thing that seems to be clear, because that also lines up with anecdote and experience in the clinical trials, that SSRIs can block, not just SSRIs actually, but serotonergic antidepressants. So SSRIs, MAOIs, when taken chronically, can block the effect of psychedelics. And this seems to endure even after the SSRI or the antidepressant is stopped. How long it endures, for how many people does it endure, can a psychedelic be safely taken on top of an SSRI? These are things that we don't know. There are studies that are I think in Switzerland, they're going to be doing a study where they give people an SSRI and then subsequently psilocybin. I think there's maybe a study in Ireland too, where they're going to be dosing those concurrently. So those are just things that, I mean, they're very simple questions you're asking. They're questions that we don't know the answer to. And so there are studies that I think are just going to have to discover that. But harm, I mean, are there drugs that can cause harm? So lithium was one that came up. I mean, there's only 2 people in the in that survey that I think that had lithium with the psychedelic. So that's not a lot of people, but I believe they both had quite bad experiences. It seemed to accentuate negative effects. And like tricyclic antidepressants, I think also seem to accentuate negative effects. And we don't, I mean, there may be a difference between taking an SSRI chronically, taking an SSRI acutely. We know that those have different effects on your brain, so it may have different effects on taking the psychedelic. In fact, I think it's likely that that's true. So our survey that we're going to launch hopefully soon is geared towards addressing some of that, not all of it. There will have to be actual dosing studies that tease some of that out too. The last thing I'll say on this though is that this is another instance in which you have people that are actually doing this by themselves. I mean, you don't, again, if you develop a new drug in your lab, you can't go out and mine data from people who are already using it to get a sense of the benefits and the harms. So that's one of the ideas, I think, to learn more.
Okay. With other like what excites you the most with new and kind of future research going forward with psychedelic therapy?
Um,
Like any particular studies that we haven't talked about yet, or just other directions of research that you think is going to be really fruitful going forward?
I think so. There's kind of the logical, just keep expanding, the same model of trial to other conditions. So I'm excited about, for example, seeing whether psychedelic therapy can help opioid addiction, which is a huge problem. And then you can just kind of keep expanding that to different conditions like OCD, anorexia, whatever. But at some point, let's say that you've established that psychedelic therapy is good for condition X. Then there are actually a lot of other variables to figure out. And this is kind of like down the road, not necessarily anything that will be done soon, but like, what are the qualities of the setting that might amplify therapeutic benefits? How can that be modified for an individual? Different people might require different things. What are the qualities of the therapeutic style or the school of the philosophy of the therapist that might impact? How about like groups? I mean, can this be done as a group endeavor? The model that we have right now for delivering psychedelic therapy in research settings is quite labor intensive, using the labor of like very skilled people, which restricts how much it can be used. So looking at things like, again, nothing that's going to happen soon, but down the road, like different aspects of integrating groups, whether that's group integration or group dosing or whatever, I think is of interest. And also, are different drugs, are different psychedelic drugs useful for different reasons? I mean, they all have similar effects, but they're different. I mean, some like DMT, 5-MeO DMT, well, they're ultra short acting. LSD is like quite long. Psilocybin is kind of medium. Mescaline has its own sort of different flavor of effects, perhaps slightly more empathogenic effects. So those are all kind of things that I think will be interesting as well. Right now, at least in my mind, there's kind of a relatively narrow focus on, um, like at least for the clinical trials, marching them forward the way they are to show, do they work or do they not work in this way?
Gotcha. Well, awesome. Dr. Nayak, it's been a pleasure having you on the show. I really enjoyed our conversation. For those listeners who want to find out more, where would you direct them to if they want to find out more about your research, or Johns Hopkins research, or psychedelic therapy?
Our website, what is it? hopkinspsychedelic.org.
Right on. Sweet. And for those listeners who enjoyed the show, also go ahead and like and subscribe to our YouTube channel. We're Roscoe's Wetsuit. And you can also find audio versions of the podcast available on Spotify, Apple Podcasts, iHeartRadio, and we're now on Stitcher. Again, Dr. Nayak, thanks so much for your time today. Really enjoyed talking.
Likewise. Take care.
Awesome.